I do have a lot of slides to get through, but hopefully we'll have a little bit of time for questions at the end. And if Annie, feel free, if you spot a question pop up in the chat, I'm happy to stop kind of and answer them. I may miss it, kind of turn it back and forth, but if you see something pop up in the chat, don't be shy. Okay, so why are we talking about this? Here, Harborview Medical Center is in King County, as is all of the University of Washington teaching hospitals, at least the core here. About half of the population increase recently was foreign born, and of the population of King County currently, about 24% are foreign born. So growing part of our fabric here in Seattle area. And more folks are coming, and more folks need to get here. We're a welcoming community for refugee population. Washington State, as of recently, was just shy of first place and second place for accepting refugees. And so kind of with global instability, more influx of refugees are coming. And some of our sister cities to the south, Tukwila and Kent, are hugely welcoming to refugee populations specifically. So not just immigrants in general, but refugees specifically. And in those cities that we serve just south of us, the number kind of gets around 40% of folks that were foreign born. So the demographics here are shifting to be to hosting immigrant refugee populations, and the hospital where we work illustrates that. The other thing to recognize is that this is a metaphor for palliative care needs across the world. You know, about 14% of the palliative care needs globally are met. So there is a huge demand for palliative care in places outside of the US. And in kind of low and middle income countries. And it's important to know that some of the skills that you can develop in kind of cross-cultural palliative care can help grow and foster palliative care elsewhere. And that hopefully palliative care programming developed elsewhere can influence the way that we take care of our refugee and immigrant populations as well. So here's some breakdown of the average number of monthly visits at Harborview that are in non-English language, kind of Spanish being kind of up at the top of the list. So about 20% of the clinic patients at Harborview or have limited English proficiency, and at any given time, about 10% of the inpatients. So it's a meaningful amount of the people that we serve. And what we know from the research is that you know, various racial and ethnic groups are much less likely to utilize palliative care and hospice at end of life. And that's something that, you know, should raise the alarm for all of us, that there's an access problem and equity problem in the way people are getting quality of life care. So the other kind of elephant in the room is that these cases are very challenging. And I think that when we approach a cross-cultural case, you know, there's some heavy lifting that the teams around us are doing and that we're doing. And so I want to acknowledge that. And I hope that some of these tools can make it a little bit easier for you. So like I said, I want to mention a case that we had at Harborview. This was a 63-year-old woman who basically developed progressive right-sided deficits, and when she came in to be evaluated, was found to have multiple meningiomas that needed urgent surgical intervention. She had the surgery, but needed a VP shunt placed, and her surgery post-operative course was complicated by abscesses with some resistant organisms, seizures, ventilator dependence, needed a tracheostomy, etc. The family was very distressed by the way that her surgical course had gone, and had been encouraged to get repeat surgery for source control of this resistant organism abscess, but they were refusing surgery, feeling that she just wasn't strong enough in their perspective to undergo surgery again, and so they were not consenting to surgery. And she kind of remained in this holding pattern in the hospital for several months, where the team was worried that they wouldn't be able to achieve kind of infection eradication with antibiotics alone, but the family wasn't willing to go through surgery and continuing the status quo. And the team felt stalled. in kind of progression out of the ICU, and palliative care was consulted for goals of care. And so, you know, I think that there are, you know, themes here that kind of apply generally to any number of families, and that's not limited to a cultural group, that I think that I hope that you'll find helpful. So I want to acknowledge that I'm going to be speaking about kind of racial groups and ethnic groups in generalities, and I don't mean that to be pigeonholing a community or kind of certainly not, you know, casting a negative stereotype, but I think that it's important that we be able to talk in dialogue in generalities that may, you know, that may represent a community, but I want to make a distinction between kind of generalization with the hope of kind of helping access and helping a community versus stereotyping being a negative kind of bias and pigeonholing of a community. I also want to say that any individual and family is just as likely to kind of express values outside of a cultural group perhaps as a part of a cultural group. And we should all know that going into the room with the expectation that an individual or family is going to behave a certain way, we usually end up wrong. So I just want to caution everyone that we operate typically on the level of individuals here in palliative care, and just to say, you know, take this with a grain of salt, that I can't speak for a person when I speak for a general cultural group. So when I read this kind of case to everyone, I want you to stop for a minute and think about what your initial reaction is as you're getting this call from the ICU team, and you hear this one-liner about Mrs. A, the 63-year-old Somali female, kind of in this circumstance where you know, the family is concerned about how her care is going, and the team is distressed about not being able to progress her care out of the ICU. So just take a moment and think about what your initial reaction is. I think that's a really important pause that we should all practice as we get calls about really in palliative care in general, just because we will have a reaction. There is the way that we make decisions and actions in our mind is influenced heavily by cases that we've seen in the past. And my guess is, for folks who have been in this field any number of months even, you've had cases that may be similar and you will have a reaction. And it's really important that you kind of own that bias. So I want to say that is one of the first most important things, is to check in with yourself, check in with the temperature of how you're responding to this case, and kind of be reflective about what your bias is going into this case, how your values, you know, may come into play, how your past experiences may come into play. Very important before you start kind of offering kind of input to kind of own that bias. And I'm going to talk a little bit more specifically about that. So basically, so this is a description of the kind of the American middle class in the 60s, kind of in the way that they generally approached death and dying. And so described as future-oriented, individualistic, bent on mastering nature, and actively taking a role, concerned with doing. Okay, so this is the kind of one-liner kind of describing this kind of general group. And I think with a little bit of interpretation, you can see that some of the fundamentals of palliative care as we practice it come from these qualities. Okay, so the value of patient autonomy, the norm of truth telling and sharing bad news with the patient so that they understand that truth, participating, giving the patient the agency to participate in medical decision making, therefore offering them control over the dying process. my sense is that a lot of these foundational kind of things that we consider foundational in palliative care come from, a pretty specific cultural view on how to approach end of life. And to kind of highlight that further, this is basically a very large summary slide where multiple cultural groups and the studies that let's see if I can the studies that kind of looked at end of life in these communities were kind of distilled. And this is specifically about advanced directives and kind of values around advanced directives. And so African American, Asian American, Latino, Native American, and European American communities were kind of aggregated from various studies. And so, my hope is not that that these values can be plugged into a computer and that you could say, oh, I have a Native American patient, so this is what their values are going to be. But my hope is to illustrate basically what I've said is that, this kind of white and European American values has kind of co-opted the norm in a way that we should all be aware of. So, so belief in an advanced directive, okay, again, this concern about control over mastery of nature and individualism. So patient autonomy, believing that the individual is kind of the bigger player rather than the family. That truth-telling or informed decision-making is done by the individual, and they need to have that truth and bad news in order to participate. And that really the dying process is something that can be controlled, and we can express ourselves with the dying process rather than something that we are kind of accepting. So I think that you can see that these European American values kind of run straight up the pole and line up very nicely with kind of advanced directives as a method. So I just want to highlight some other circumstances where that might not be universally applicable. So in some studies showing that Korean families wouldn't feel like giving the patient the onus of making a medical decision or life support decisions would be appropriate, and the family really should be doing that. Another example, kind of with the Latino patients, maybe kind of appreciating the informed authority of a physician to kind of tell them really what they think would be best for them. And again, this is not to speak for these communities as a whole or the individual patient, but just to say that that some of these values may be different than what we'd expect. And importantly, I wanted to highlight that the Native American community, you can see, generalized, and it's a very large and homogeneous or heterogeneous group to generalize with, but that there's concern that a lot of the norm may fall outside of values for this community. Okay, so it's a community to be extra attentive in our approach, such that when assessing for advanced directives became mandated with every admission, there was a lot of concern in how Native American communities were going to handle this kind of question. So part of owning your bias is owning your Western bias. Okay, so it's important to know. It's important to know that palliative care is comes with an inborn Western bias. Okay, so the other thing to know is that we also have a healthcare provider bias. Okay, studies will show that young doctors surveyed, about almost 90% of them would say they would not want CPR done in the setting of terminal illness. So this is not the general population. Okay, so of cancer patients getting radiation therapy, about 6% would say they don't want CPR. In the ICU, about 10% are DNR. And so you should know that our healthcare values are very different from the population we serve, the second part of that is that when I was approaching palliative care as a trainee, I thought, oh, I'm going to be good at palliative care because I can say things nicely and I can convince people to do kind of the right thing by putting it in a nice way. And, you know, that's not really what palliative care is. Palliative care really is a thoughtful assessment of someone else's values, so that you can help make the care fit them better as an individual. And so it's not advertising that we're doing. It's assessing and learning. And so just be careful that when you find yourself in a position where you've been given the task of saying something that is kind of antithetical to a patient's values, but saying it in a nice way, maybe we're missing the point on that in that moment. Alignment really is the goal, okay, more so than kind of convincing someone to do what you want them to do. It's also important to kind of normalize that we do talk about these things in our healthcare system. And I had a Kenyan patient at our clinic in Harborview came up to me and she was like, "Doc, why when you come into the hospital, the first question out of their minds is, do you have a will? Like, that's terrible. Like, why would you tell someone who's sick, you know, are you prepared to die? That's just the worst thing you could possibly say. Like, I want hope. I want to be optimistic. And you're saying this terrible thing." And it's we should be kind of sensitive to that difference and what people feel is appropriate, but also to say, you know, in our system, people tend to value a lot of control. In our system, people want to feel like they're driving and they want a lot more information and that sort of thing. So you can try to normalize some of that with people as well, that it's not, that it is kind of a result of the system. This team, when they called about the patient that I kind of highlighted earlier, you know, the family just doesn't get it. She's not going to wake up there, you know, this doesn't get it kind of mantra. Some of the team members had felt disrespected by the family, and the family was at the bedside every day, and they were kind of pushing for diagnostics and criticizing kind of the care team, kind of doing the day-to-day care, and a lot of the team members felt like they'd been disrespected. People were feeling, well, if they're not going to accept kind of the usual care, that we should discharge them. And then people would also kind of almost invariably mention the cost of what this was costing the healthcare system. And so when I hear these things, this frustration, this kind of flippant, we're just going to discharge them, like just discharge them, you know, let them figure it out. They don't want the care, etc. Or talking about how expensive this is, what I'm really hearing is the kind of moral distress of being a provider in this circumstance. And it's so important for us to listen for these things and engage with the moral distress around us. And I think that this is one of the kind of crucial roles of the palliative care team kind of in the larger organism of the hospital and healthcare system, is to kind of hear this distress, identify it, try to help it where we can. And so reasons being, it leads to burnout. When there's moral distress, the team carries it around on their face. It's in the tone of their voice. It's in the kind of tone of the care that they give, and families pick up on it. I mean, they smell it a mile away, and they misinterpret it. They don't see it as, you know, the nurse who feels distressed that the care that she's providing is hurting the patient or is harmful. But what they see it as an uncaring, so the exact opposite, and it leads to a lot of family distrust. And so making people aware of that can be really helpful to reduce it. The other thing is that we see this a lot. Are we goals of carrying someone to death? Well, it's 2 days later, let's go assess their goals of care. Like, let's talk about, you know, once again, tell them, you know, that they're dying and there's nothing we can do, and they need to make a different decision today. And, you know, when honestly, when people's values have been made clear, you know, you know, Caroline Hurd's voices in my head, but they just need to see more of how this road is going to go. and experience this a bit more, and rather than having the opportunity to rediscuss it over and over again in very short intervals. So just be careful about that dynamic, and to set some expectations for the consult. Essentially, we can't solve in every kind of challenging circumstance such that people can be discharged. But we identify some things that you plan to help out with that are concrete while you're talking with the team. So what I think is the most helpful thing, or one of the more helpful things in dealing with moral distress, when you just get this vibe from the intern who's taking care of the patient, or the bedside nurse, or the social worker, you're getting this concern that's coming back to you. Help them understand a different perspective on what they're seeing and humanize the family's perspective. Okay, so when you have a family that says, oh, you can't tell mom about her cancer because that will kill her, some folks might have the values that denying patients this information is deceitful, and certainly denying people information when they want it is not what I'm advocating. But in many families, this is how the decision making goes, and kind of leaving the burden of decision making to the healthy family members rather than the sick loved one is very common around the world. So normalizing that and just letting them know that there's actually a caring perspective on this, which is protecting your family member from stressful information is actually familial duty. Okay, so it's not something where they're being deceitful, they're being honorable. So helping someone see this other side. Okay, another example of that is, we really shouldn't pursue aggressive measures due to futility. We're just not going to do it. And the family's perspective might be, we're being denied treatment that may be potentially life-saving, and maybe it's due to discrimination. So being mindful that a family might have a different perspective on, when we say it's futile, they might see it as a denial. So helping people hear this other perspective. We put a lot of emphasis on quality of life, rather than kind of duration of life. And we say, like, we might say, if you're stuck in this unacceptable quality of life, that's a very cruel thing to do to somebody. Other people might look at it differently and saying, if you were to die when there are things that could have kept you living, that might be a better descriptor of cruelty. And again, I'm not trying to have a horse in this race, but it really is trying to humanize this other perspective. Okay, and when you hear the doctor say they just don't get it, many families and many faiths feel that doctors are not the almighty authority on what's going to happen, or on prognosis, or when someone's going to die. And many families see that sort of prognostication, certainly with any certainty, as kind of arrogance, and maybe offensive arrogance at that. And so just know that it might not be that they don't get it. It might just be that they don't value the doctor's opinion on this thing as the end all be all. And so just to say, people get their information and kind of sense of what's going to happen from lots of different sources. So try to familiarize yourself with this practice of showing the team, the family's perspective in a way that is not malicious. Okay, and it's not a careless family. I mean, these families are oftentimes at the bedside, a heck of a lot longer than the care team is. And so just to kind of humanize their perspective a little bit can go a long way. So another tool that I hope you all will investigate, particularly if you're coming from You're joining us today from elsewhere is Ethnomed. And Ethnomed is an amazing resource that was born at Harborview, and it offers a lot of context for immigrant and refugee communities that we serve. And that might be what's some of the background that kind of led to this refugee circumstance that people have found themselves in. What are some important cultural kind of components, and what are some basic primers on introductions and language, but and some of this is specific to health, kind of what health practices you might see, whether holistic kind of approaches to health or diet, etc. But also there is some specific information for end of life practices, and so it's a important kind of hub for a very large, expansive kind of information about cultural communities and how they interface with healthcare. And so I would encourage you to browse it, even if it's not an end of life issue that you're engaging with, but just how is fever interpreted, or how anyway, it's a very expansive data point. So I would encourage you to kind of browse Ethnomed. So I wanted to take a moment also, because in these circumstances, interpreters are so critical, and how we use interpreters is so important. I wanted to highlight some basic interpreter skills that we should all practice. So how do we use interpreters? I say this because I work in the hospital, and I know kind of the time pressures, and a lot of times you're like, oh, the nurse is right here, they speak Spanish, the patient speaks Spanish, let's just get it done, and I'm gonna use the nurse who's here to talk for me, and the nurse is fluent in Spanish, no big deal. So just so people are aware, in studies of hospital staff who are fluent, okay, so absolutely fluent in the language we're talking about, they make errors about 50% of the time when it comes to medical interpretation. So, and that also includes family members. So, it's really important to use an interpreter. And I appreciate Annie's language when confronted with a family that says, hey, we're good, we're going to use our family member as an interpreter. Say, this is for us. This is so I'm sure that I communicate as well as I can. And this is just kind of what we do. I'm going to normalize that. And it's, rather than using family or nurses, because it's not good practice. And in some families will be insistent, and you will have to decide whether losing capital with them is the most important thing, but really gold standard is using an interpreter rather than bilingual staff or family. So there are studies, which I'll show you here in a moment, where in end-of-life interpreted end-of-life family meetings, we take less time with a family meeting via interpreter. And that blew my mind. The first time I read this study, I was like, that's impossible. I get like an ulcer just thinking about how much time I'm about to spend going into this room. And maybe that makes us overcompensate, but the studies will say that we spend about 6 minutes less time in an interpreted family meeting. So in spite of the fact that things are being said multiple times. So just be mindful of that truth. The other truth, which was surprising to me, is that we use fewer empathic statements when we use interpreters. And maybe it's the artifice of speaking through another person, and it just makes it a little bit harder, but it's something to be aware of and to work on. And so here's one of the studies that some of this information comes from. And I start a couple of statistically significant differences. One is expressing appreciation or gratitude as a form of support. And you might know that as the respect statement from the NURSE acronym, but acknowledging a family's contribution of being at the bedside, or acknowledging their contribution to caring for the person there as a form of support. Showing emotion, statistically different, and making statements or asking questions about the patient as a person. So I think we would all acknowledge that it's impossible to do our job as a palliative care provider without acknowledging the patient as a person. But statistically, we do it less in interpreted conferences. So be mindful of that. Perhaps, and maybe we all get to a place where that's not as much of a concern for us, but see it in the teams that are around us as well. So a couple of other kind of primers on our pearls for working with an interpreter. Part of our practice at Harborview, if we go into a family meeting with an interpreter, specifically a cultural mediator, we try to pre-huddle beforehand. And that pre-huddle is where you broadcast what you're planning to talk about with the interpreter. It's very difficult to be an interpreter and to go into a meeting and not realize that it's about to be a very serious meeting talking about end of life and discussing topics that are going to be upsetting or triggering. And so letting people know kind of what is on the agenda is very important. Assessing from the interpreter cultural mediator, are there taboos that we should be worried about? Talking about cancer, TB, HIV, things that might be important to kind of understand the background and baggage that comes along with that language. Are there kind of cultural norms around decision making? Like, oh, I'd expect this patient to defer to their eldest or something along those lines. Are there patterns of decision making? Are there nonverbal forms of communication, i.e., if I'm staring someone in the eyes, is that a sign of disrespect or respect? If I cross my legs and I show someone the bottom of my foot, is that something that's offensive? And so just to have a general sense, is there anything that you see commonly where people, might offend? So I would say, those are some of the things that you're going to talk about with the cultural mediator ahead of time. Okay, setting up the room. Okay, so really you're trying to set up the room so that the patient doesn't have to pan 180 degrees from the interpreter on one side to the person asking the question on the other side. The person should be able to comfortably sit and have the interpreter and the person who's going to be doing the most speaking kind of in a comfortable line of view. And consider saying "Tere yesteling" for yourself. So this is hello in Amharic, which many of our Ethiopian community members here in Seattle speak. A basic greeting, and it's not to go in pretending you speak a language that you don't, and it's not to be cavalier about a language, but it really is illustrating that you are invested, you care, you see this person. I don't know how many of you have had the experience in traveling where you say hello in Arabic or in another language where you're traveling, and people just stop and they say, "Oh my gosh, your Arabic is beautiful," and you literally say hello, and people just acknowledge the effort and they see it. So I like to greet people in their comfortable language, and again, not to usurp interpretation. I have a hard time with this one. Okay, I think we all do. I'm very wordy if you haven't learned already, but trying to keep it to 2 sentences that you're interpreting. Because we try to be so precise, I feel like oftentimes we just keep throwing in clauses and modifiers, and so try to avoid that. Really cautious with humor. I love the use of humor in palliative care, but it's sometimes doesn't land well in translation. And like we learned on that previous slide, where we use less empathic languages. So try to be explicit with your empathy and be sure that you kind of that you're remembering to be empathic. So some of the common conflicts that I see in these cross-cultural cases
Oh,
So,
Jody, can I
yeah,
pause you? I
yeah,
just
please.
want to, I have not been doing a great job of
Oh,
bringing up comments because there have been some really good ones. One that I'll go
yeah,
back to at the end when it's time for questions, and the other because I think it'll generate some good conversation. But Amy, Dr. Trowbridge put in several comments, and
oh,
so I
great.
just want to highlight her comments. And Amy, if you want to unmute yourself, go ahead. Or if you're in a space where you can. Otherwise, I'm happy to also just read off your comments.
Oh, sure. I one of my mentees and I just had a paper accepted. It'll be published soon, looking at the empathy statistic that you cited from Randy's old work from a long time ago. And some good news is that at least at Children's, almost 15 years later, there's no difference between empathy expression and interpreted and non-interpreted care conferences. Of course, there's other differences and disparities certainly still exist, but at least some good news in terms of empathy in this other setting. And then
Absolutely.
I also just wanted to throw a shout out to one of our palliative care colleagues at Children's, Elisa Van Cleve, who did some work in interpreted care conferences as a part of her ICU fellowship, and found that the threshold about 20 words is that sort of when, if you're asking your interpreter to interpret more than 20 words, the error rate just kind of skyrockets after that.
Yeah, that's helpful. Thank you, Amy. And I have no doubt that kind of the way things are going at Children's is a result of everyone's hard work up there, and kind of being attuned to how we need to be more conscientious about expressing our empathy, and I'm glad to have that kind of update. Yeah. So Annie, thank you for poking me at, and anybody else, honestly, feel free to key up your mic and let me know if you have a question kind of about a slide in particular. Because I think we're doing okay-ish on time. So basically, some of the common conflicts that I see, and these themes come up in our consults. The family doesn't believe or appreciate the medical prognostication, and as I mentioned, it's good for us to hear this. Take our role in the world with a little bit of humility, and that people, some communities get their information not exclusively from doctors regarding their health, and that might be a news flash to some, but for some people, their church community has as much or more to say on how their health is going or will go, or their family, or what they've seen from their own experience. So it just it's not that the family doesn't get it, but teams are oftentimes not expecting when families just kind of shrug off the bad news that they're giving them, and it might just be because they're that's just the doctor's perspective, and they don't value that as the end all be all. I hear this a lot also, and that people may get treated differently on the team, and again, this shouldn't come as a surprise, but there's a lot of hierarchy in medicine, and which we're working to kind of dismember. But I think that families might sometimes are coming from a place where that hierarchy is kind of much more the norm of how things work. So you might find that they are harder on people that they identify as kind of lower on the totem pole. So whether that's residents or trainees or other kind of team members, that they if they don't get a sense that they're kind of at the top of the hierarchy, they might not be as patient or respectful, and that's something to kind of acknowledge and kind of support our fellow team members with. Again, this should not come as a surprise to anyone either, but almost universally, I hear from my patients that they're worried that even at Harborview, even when you walk in the door, and it says right on the door that our mission is to serve immigrant refugee communities, there's concern that they're going to get different, worse care based on the fact that they are immigrants, the fact that they may or may not have insurance, the fact that they have Medicaid specifically, that they don't speak the language, so, and these things are born out of reality, okay? And again, it's something that we're working on as a community and facing as a community, but, unfortunately, a lot of the damage has been done in terms of our credibility, and people just are anticipating being discriminated against, and they're often right. And so anticipate that that's the lens that a lot of people will be seeing their care through. So use of respect statements, as I said in that previous study, I think in communities where there's a much more established kind of filial duty for the younger generation to take care of the older generation, I see this a lot, that respect statements of acknowledging kind of the contribution of the family really goes a long way. So, you've raised your kids well. They're here at your bedside taking amazing care of you. You must be a really special partner because your partner's here at the bedside so much. Kind of these respect statements, I feel like, carry a little bit more weight in these communities where the family decision maker and the family maybe is valued higher over the individual. So I would remember that. And if you've got to choose a nurse statement to make, keep an eye on those respect statements. So inshallah or alhamdulillah. So in Arabic and in other language with Arabic kind of vocabulary, inshallah means, thanks be to God, or kind of Lord willing, and alhamdulillah meaning thanks be to God. And these are kind of ways that you can express hope, inshallah, Lord willing, that will happen, or gratitude, thanks be to God, alhamdulillah. And these, I think model the fact that, no palliative care providers that I know are going to claim to be all powerful. And these are like small clues that show that you're humble in working with a community, and that you leave some of what's going to happen to another authority. I also think that expressing uncertainty is something that sometimes communities read as kind of inadequacy, or kind of being less than as a provider. So you could say, we don't know what's going to happen, and that might be perfectly true. And it's not to have a false sense of arrogance, but if you want to express that uncertainty, it can be better received if you are speaking from your past experience. In my experience, I've seen patients like this go this way, and I've seen patients like this go this way. So you can express that uncertainty, but it is a feature of your experience rather than saying, I don't know, because families might just say, well, if you don't know, find me a doctor who does. So you want to be sure that they have that information. I find, in a community that is used to operating in a hierarchical structure, using that language can be very helpful. So, with this case that I mentioned, the family said, oh, we have worries about our nutrition. And you say, okay, we're going to get the nutrition expert, i.e. the nutritionists in our hospital. They are an expert on this. And we are going to bring them in to address this, or I use that language, the expert, or the kind of the best authority in these circumstances, and I kind of play them up a little bit. This is not to throw other members of the team under the bus, and I try to also say, we work as a team at Harborview, and I want you to know that everyone's perspective is important. And so protecting other members of the team that seem to be getting targeted by the family, but use that term expert liberally, and talk about what people are doing. Okay, that language of we're going to stop doing X, Y, or Z is never well received. And so fill the air with things that you are doing, because there is hard work every moment, even obviously with a comfort care patient, the work of the nurses, et cetera. Make sure that they get that airtime, that is talked about, and the family is shown kind of what that work is it's being done, and so that's not taken for granted. And always make a habit of expressing non-abandonment. No matter what happens here, we are going to be in your corner. You're never going to be by yourself. I don't care what kind of insurance you have, all of, expressing and making explicit non-abandonment. The other thing I'll say is we've had a couple of cases on the inpatient service here recently, where the family is trying to get a loved one to visit from abroad. And so Patty Murray's office has been particularly welcoming when it comes to kind of contacting them through the website, and asking them for help and advocacy for visas, et cetera, but offering the family something concrete. Okay, so I do think that there are times where we are kind of only offering nurse statements, and that's all we got. And I think that we should really try to do something concrete for all of our families, but for these families in particular. And this is something that can be helpful. Okay, so our case, basically this woman, she spent 7 months at the hospital with her family, essentially at the bedside almost the entire time. She got discharged home because this family miraculously converted their garage into basically an ICU. They learned how to use a ventilator, they learned how to do trach suctioning, and they basically were trained on how to be amazing caregivers. They rallied a incredibly robust and deep family support system, where they had multiple family members kind of learning the skills they needed to take care of her at home. She had a couple of setbacks in that she had some viral infections, secretions that wound up back in the hospital. But she went from being in a vegetative state to being oriented and moving all of her extremities, and coming into primary care clinic. She graduated from the ventilator and had her trach removed. She had no residual infection from the abscess that was deemed to never be curable with antibiotics. She was on antibiotics for several months and had no residual infection. And she's getting to the mosque with her wheelchair with her family's help. And the family was thrilled, and they were so happy kind of with how much improvement she showed. So we'd say, thanks be to God. That was a really kind of a miraculous thing that happened. And with great humility, I think that we'd say, none of us were really expecting that to happen, and that's okay. So I'm going to make a quick pitch for the Community House Calls program, which is at Harborview. Basically, this is a team with a nurse manager and multiple caseworker cultural mediators from 6 different communities now. So Amharic speaking Ethiopian, Cambodian, Vietnamese, Latino, and Somali, and some with specific training in diabetes, some with surgery navigation, and a newly minted Afghan cultural mediator due to our growing Afghan refugee population. So these providers are coming from the community and bridging the kind of Harborview / healthcare community, advocating for patients. Yes, they do interpretation, but they advance people's care outside of the clinical kind of, appointments, et cetera, and really help a good conduit of information go back and forth, and help people get good care, and are well respected in the community, truly. So when you're at Harborview, it's a very low threshold, certainly for the palliative care consults, to bring in the help of the Community House Calls / cultural mediators. I was fortunate to do an outreach with help from the cultural mediators in the Candia Palliative Care Center of Excellence a little while back. And we developed some outreach materials with the cultural mediators for some of the 5 communities that they served, basically talking about end of life kind of nuts and bolts when it comes to palliative care, decision making, And we started these outreach events with a meal together, and I think that this was very important. These were all in community center settings, and I went oftentimes with the cultural mediator, also with the nurse manager, and we would all sit down in a room of 10 to 25 people, and we'd all eat together before we started talking about anything, and it gave everybody a chance to socialize and get to know people a little bit. And I started the outreach with a blessing, okay? And it's a culturally kind of tuned positive invocation before we started, because we're going to be talking about hard things, and it's important that people know that we are hoping that people have long, healthy, happy lives. And whatever is the authority in that domain, we would like to positively invoke it before we talk about some of these hard things. We did a little bit of a survey beforehand in the presentation, collected some data afterwards. Okay, and the presentation was about 45 minutes or so. And then we just had a QA for a period of time after the fact. And it was a wide range, and people were typically quite happy and asking a wide range of questions about some of the material at hand or their high blood pressure. But it was an opportunity for people to kind of put me or anyone else on the hot seat a little bit. So some of the data that we got was, yes, it is uncommon talking about end of life, and this is kind of a representative kind of sample of one of the communities that we engage with. But yes, it's uncommon. So no big surprise there. However, at the end of the session, most people were saying this was pretty good. So 18 out of 23 people were saying, I'd recommend this to a friend. And we're talking about death. We're talking about quality of life. We're talking about kind of healthcare decision making, and people felt like it was something that they would recommend. And if you don't believe me, you can look around the room, kind of, this gentleman has a big smile on his face, and this really spoke to the temperature of the room. And when we can have these conversations kind of outside of the pressure cooker of the ICU, where the medical provider is one and the community is many, and people have the authority to ask questions, it really changes the dynamic of what these conversations feel like. So I was really happy that there were a lot more smiles in the room that you might expect. So to kind of sum things up a little bit, really, really important. You pick up that call, you hear it's a cross-cultural case or a case in general, knowing that your opinion and your ideas are so influenced by your experiences of the past. Really important to own your own bias and own the bias of palliative care in general before you go into that room. The moral distress around you will poison the kind of staff and families interactions, and it will shorten careers and make people really unhappy. And so the more you can engage with that with help of reframing, et cetera, can be good for the hospital community as a whole. Taking a moment to do some homework, learning an introduction or learning the background of a refugee community can be helpful, and using ethnomed is a good way to do that. And just remember that the overarching principle of palliative care is not how do you advertise your values so that someone else will drink the Kool-Aid. It's really how do you assess someone else's values in the medical context and support them in pursuing care that aligns with those values. In some communities, doctors don't know when people die, and we're not well received when you try to tell them that you do. So just know that people get information from elsewhere, and to be humble, speaking from your experience when you can. Slowing down and using empathy explicitly when you're using interpreters. and getting out into the community. I think it's a really great way for us to kind of flip the traditional paradigm of the family meeting inside the hospital. I wish we could engage more with people upstream, and answer questions and give them insight into the healthcare system before things get so hard. So we have a few minutes left, and I can run back through chat.
So yeah, Jody, I'm going to point you to the comment that I thought would be great to just address at the end. And I see the person who made the comment is on video. So if you want to unmute yourself, it's the comment about generations and how they might differ from their parents in making some of these decisions.
Absolutely, absolutely. I did see that comment. And if everybody could look at the question in the context box, but for, you know, how as the level of as people may become kind of acculturated or have evolving kind of end of life practices or values with successive generations. And I think that is very real. And it is, I know there's, you know, specifically really strong studies related to the Japanese community as well, that with successive generations, that the way that they engage or appreciate medical information is evolved. So it is that I think that's part of assessment also, is kind of getting a sense of, you know, how acculturated or potentially is there a acculturation potential conflict between the younger generation, you know, that you're engaging with versus kind of the older generation that may not be participating as much.
And
so
you and I are
appreciate
both
that.
like big fans of like This American Life, but I
Oh,
know you and I talked about the episode that generated the movie The Farewell,
Absolutely.
but like Nai and
Yeah.
her granddaughter.
Yeah.
If any of you haven't listened to that, like I highly recommend it.
Yeah, absolutely. It's Lulu Wang,
Lulu
I
Wang,
believe.
yeah.
Yeah. So she did a piece for This American Life before the movie was done, where she talks about how her grandma had advanced lung cancer, and how the family kind of engaged and wrestled with how best to share that information. And it's a really humanizing kind of family kind of portrait. Yeah, thanks, Annie. That's a really good thing to people to listen to on their drive back home from work today.
And I know we're kind of at the end of our time, but I want to give the original commenter like a chance to comment too. You're unmuted.
Oh, Jody, it's great to see you. This is Leah. I'm over at Swedish, and we're seeing increasingly a number of Indian Asian families of the Hindu faith background or cultural background wanting to connect with people who can guide them through caring for aging parents. So what we're seeing with the second generation and multiple cultural contexts is, what do I do to honor my parents? How can I do it well? That older generation is kind of, you know, we're not as connected to them. So people needing help kind of digging up a resource for themselves, or figuring out, who do I go to when I need these rituals? Who do I go to? So it's really important for us as spiritual care providers, as healthcare providers, to kind of maintain those contacts with diverse communities, because I think this will only become more of an issue as our populations age, wanting to help people honor one another and kind of reconnect to those contexts, or even allowing people to use the hospital phone to call, like, I need to call my uncle and figure out, what do I do right now for mom?
Absolutely.
You know, what kind of decision do I make? That's the generation who's got to say something. And so thank you so much for surfacing this.
Oh, absolutely. And yeah, I want to acknowledge how important the role of the spiritual care team is on our multidisciplinary team as we approach cases like this. It really is, it's the special part of our work that we have so many different members of the team, because these are the cases where the fruit comes to bear, and it like you said, kind of maintaining a connection to that practice oftentimes is what gives the family some healing. And I'm so thankful for our spiritual care providers for focusing on that and offering that.
Oh, I just wish we had cultural mediators in our context. So sending a big
Yeah.
heart your way.
Yeah, well, keep advocating. So just so you know, there is anybody who's interested, email me. There is some kind of background into the formation of the cultural mediators at Harborview, and kind of why and how it got started. If people want to, mine it for talking points for how to engage with their administration, saying, hey, this is how we take good care of people. For lots of reasons, please let me know. And I hope we can grow cultural mediation and programs kind of nationally, because I think that everybody agrees that they're important. All right. Well, thank you guys so much, Annie. Thank you so much for having me. It's so good to be with you all talking about such important work. I'm excited to go forth. Thanks.
Thank you. And we'll see the fellows in